Good morning. Welcome to St. Mary's and a special welcome to visitors from other parishes. On behalf of St. Mary's Respect Life Committee, the Knights of Columbus, and our parish clergy and staff, some of whom were at a funeral unfortunately, thank you for attending this talk on some of the most difficult issues we will ever have to face. End-of-life issues affect everyone and every family, sooner or later, in one way or another. And in many instances, our loved ones who are distraught and in emotional turmoil get overwhelmed, either from a lack of information or guidance, or too much information, too many recommendations that may conflict with each other, or with what we believe is best for our loved one, or even cause us to question our understanding of the Catholic faith on these issues. We are blessed this morning to have DiAnn Ecret from the National Catholic Bioethics Center, who can help us understand these issues from a Catholic perspective and give us confidence that we will be able to make decisions that are morally and ethically in accordance with God's will and our Catholic faith. DiAnn has an extensive background in nursing and academics. She graduated from Our Lady of Lourdes School of Nursing, completed her BS and MS degrees in nursing from Wilmington University, obtained a master's certification in theology and ethics from Villanova University, and holds a PhD in healthcare ethics from Duquesne University. Did I leave anything out? DiAnn joined the National Catholic Bioethics Center in 2016 and is currently a staff ethicist, nurse planner, and a full-time assistant professor of nursing at Ave Maria University. She has 35 years of combined nursing experience in adult, pediatric, and neonatal care, critical care, nursing, nursing management, and nursing education. She is on the Healthcare Task Force at Life Perspectives and serves as a member of the President's Bioethics Committee at the University of Mary of Minnesota and volunteers as an ethics consultant for Be Not Afraid. She's married to her husband Mike for 34 years and has 4 children and 2 grandchildren. So we couldn't have a better authority with us to speak about end-of-life issues, medical, moral, and ethical guidelines in accordance with Catholic doctrine and Catholic teaching from an accomplished Catholic medical professional and nursing professor. So it is my honor and privilege to welcome and introduce Dr. DiAnn Ecret.
Thank you, Tom, for that introduction. I'm a klutz, so I dropped everything. It's truly an honor to be here with all of you today. I'm a South Jersey country girl. I was raised by my mom and dad in the faith of the Catholic Church. And I met my husband when we were just 17 years old, and we have been best friends and faith partners for 35 years in November. And through all of that, I always say, God leads us where God wants us to be. And as a nurse, working 12-hour midnight shifts in many different ICUs and scenarios, and encountering many ethical dilemmas, you have to be careful what you scream to God in the middle of the night. And the screams that I screamed to God in the middle of the night were from my heart and not from my lips. My poor husband might have heard a lot of the screams verbally throughout time. And the questions that I asked God, the questions that I wrestled with, that I viewed all of humanity, that it felt like all of humanity suffering with, led me in a direction that I never anticipated. I love being a mom. As South Jersey farm girls, we used to can vegetables and spend many, many days in the fields, and then happily raised our children. So when God led me in this direction, it's a humbling experience to be with all of you. My humble journey began spending summers with my grandparents in farm country in Ohio from immigrant Italian descent. And we spent many days, meals in the kitchen, gathered around the kitchen table, speaking with my grandfather, who was Franciscan lay, and my uncle, who was also Franciscan lay, discussing things in the early 70s in relation to end-of-life decision-making, dying. My grandfather was in the Curcia. He was a humble, quiet, wonderful, loving grandfather. And we would walk with him while he provided Holy Eucharist to the sick, to those in nursing homes and in their own homes. And then we would sit around the kitchen table, and I kind of feel like I wished we were all sitting around the kitchen table right now, all of us in a circle, so that we could talk about end-of-life issues and not be here on a pedestal, but we're before Christ, and Christ is with all of us. So that being said, before we get started with the formal talk, I like to begin with a prayer to the Sacred Heart of Jesus so that we can all embrace our lives and our trust in Him. So in the name of the Father, and the Son, and the Holy Spirit. O most holy heart of Jesus, fountain of every blessing, we adore you, we love you, and with lively sorrow for our sins, for my sins, I offer you this poor heart of mine. Make me humble, patient, pure, and wholly obedient to your will. Grant, good Jesus, that we may live in you and for you. Protect us in the midst of danger. Comfort us in our afflictions. Give us health of body, assistance in our temporal needs, and your blessings in all that we do. Through grace of our Lord's holy death. Amen. Merciful Jesus, we consecrate ourselves today and always to your most sacred heart. We live in turbulent times, and I don't have to tell all of you that we live in turbulent times. Life used to be more simple. I had the fortune of being raised in the profession of nursing by the Franciscan Sisters of Allegheny, and they were our mentors and they were our nursing leaders. And fortunately, in my nursing education, we didn't have Catholic bioethics per se, but we had the Franciscan Sister of Allegheny's moral compass guiding us in everything that we did. So I often want to thank Sister John Francis, who is in heaven looking down on us going, good grief, they really have DiAnn talking to everybody. My Italian grandparents and these good sisters, the Franciscan Sisters of Allegheny, they lived by example the truths of Jesus Christ. They recognized Jesus as our shepherd, that even when we felt alone, we are being carried on Christ's shoulders in our most difficult times. And in times that we want to help our loved ones and our family members, we can surely depend that Christ is with us, even like St. Teresa of Avila would say, when we couldn't feel his presence, we know and trust in his love for us. We know in life that there's one certainty, and that one certainty is death. We all cannot escape death. Christ came, led us by example, and showed us the way, the truth, and the life through his crucifixion and resurrection. This is something so dear and so precious that I'm sure none of us take for granted. But Christ's redemptive and saving grace embraces each and every one of us, but embraces everyone that we encounter, especially when people are sick, when they're suffering, and when they're facing death. As a nurse, and because I worked in pediatrics and neonatal ICU, there's nothing more beautiful and sacred and like hollow ground than witnessing the birth of a baby. No matter how many complex births I would go to, I would always be in awe of God's grace of new life and get a tear in my eye before we put the baby on the isolette to do our work. And maybe not so surprisingly, the same hallowed ground, the same sacredness occurs when any one of us leave this world in the hands of God and transfer to eternal life. And it's not something that many of us know exists. When I was in nursing school, I had not yet seen a human being die. And the first person that I participated in coding with in an ICU as a nurse's aide, the nurse was like, get on the chest, do the CPR. And it's something that all of us would probably hesitate and pause with. And the first thing that I did when I made my first compression on that chest, as opposed to a mannequin, was rhythmically say Hail Marys. And now at Ave Maria University, I have 34 nursing students who profess that their call to nursing is a true call to nursing to live in God's mercy and grace. And they too say that's what they do, is that they pray. So for all of us, and for a dear friend of mine named Sister Anne Sophie, she wrote a book about what is the best way to prepare for death. And the best way to prepare for death is our spiritual preparation. All of our end-of-life planning should include a care plan, so to speak, of what we want to tell our children and those who love us that we would like to have spiritually at our time of death. In the 1970s, this wasn't an odd request from any of us. And at Our Lady of Lourdes Medical Center in Camden, New Jersey, every person who was in the hospital at time of death would have someone helping to say prayers, even in a different prayer faith tradition, as a normal part of their wellness, their healing, their care, and their end-of-life preparations. Today, unfortunately, we've moved far away from that. Your parish's prayer for the United States, for our government politicians, to be able to reflect upon the intrinsic dignity of life from the moment of conception until natural death is really a beautiful prayer. And I have not heard another parish include that in their prayers and in their novenas, and it has touched me. So I'm going to ask Marianne and Tom if they can provide me with that prayer and maybe take it to my parish in South Jersey and in Florida. Our current secular culture, current non-Catholic, non-Christian, non-religious, non-Judeo-Christian culture functions in healthcare today on a set of secular Catholic bioethics standards that include the principle of autonomy, the principle of beneficence, the principle of non-maleficence, and justice with scarce allocation of resources. And I'm going to explain those just a little bit, but just kind of pop out that the secular view of allocation of resources and justice is totally not the same as our faith tradition in the Catholic Church of social justice and solidarity. In the normal world that we live in, autonomy or self-determination has been created into the new end-all be-all, that whatever anybody wants is what everybody should get. That affects end-of-life issues at the beginning of life, and it affects end-of-life issues at the end of life. And I'm only going to quickly mention beginning-of-life issues. I do a lot of work with couples who wind up with what they call NIP tests, or genetic testing, at 8 weeks gestation, when parents are super excited about having a baby. And they can receive diagnostic information that's not diagnostic, but secular medicine makes it seem it's absolute. And families are offered interventions that only include termination of the pregnancy if they think a child might have a genetic abnormality. We're moving into a eugenics type of a culture that says if anybody's going to suffer, anybody's going to have disabilities, anybody's going to have genetic abnormalities, well then it's our obligation to not let that person be born, because after all, we wouldn't want them to suffer, right? You don't want your child to suffer. And if all of you or any of you have had children in this room, we know that our normal life condition is one that's not separated from Christ, and it includes human suffering. And there's no way any of us can avoid it. So I ask you to say prayers for those couples who receive those poor prenatal diagnoses. There's an uncountable number of children that are aborted, and many couples, even good Catholic couples with the language that secular healthcare is using, aren't even aware that they had an abortion until they get the bill in the mail that says that they had an abortion. They think that they're getting a treatment intervention, but it's about lack of education, and we do a lot of consultation for these couples. Beneficence in healthcare ethics means that we always seek to do the good, as long as the good is defined by the autonomy of the person who states what good they're trying to achieve. Non-maleficence means that we will do no harm in healthcare, and we attest to this practice standard in our professional codes of ethics to always provide the good for a patient and to avoid harms. But when healthcare uses heightened euphemisms regarding treatment interventions and end-of-life decisions, then there's documented proof that there's sometimes trauma that is caused by that language. And our end-of-life decision as we age is no different. And I'm going to explain some of the changes that have happened in healthcare. You will not hear the term euthanasia. You will not hear the term physician aid in dying. And when you log into State of New Jersey end-of-life decision-making, you'll see the MAID, M-A-I-D. Has everybody heard of MAID? Medical aid in dying. Compassionate care, death with dignity. The changes of these terms indicate that healthcare and people are entitled to compassionate care and medical aid in dying, and those of us who have conscience protections to not end life prematurely are being identified as people with our own value biases, and that we need to not incorporate our value biases into the care of other human beings, and we need to respect their autonomous decision-making capabilities. And that's the scary culture that healthcare professionals are now living within. And it's the scary culture that all of us have to carefully try to pay attention to what is being said to us and try to receive some type of direction from our moral faith tradition to lead us in that decision-making for our loved ones and for ourselves. So how did we get here today? How did society stop seeking truth and seeking truth that was pretty much considered what some secular people call common morality? And when I taught nursing at Thomas Jefferson University for 10 years, I taught ethics to the new nursing students, and I would say we had 50 to 60% of our students that came from Holy Family and Newman and Villanova and St. Joe's, so we had a good number of Catholic nursing students. But when I talked about common morality in all of cultural traditions include basic things such as we shouldn't kill other human beings. We shouldn't lie, we should tell the truth, and we should be compassionate and loving and caring for our family members when they were sick. And that common morality was not attached to religious biases, as we're being told it is now. Values that were common in the United States in the 70s, 60s, 70s, when I was growing up, are unfortunately not always considered our social and cultural norms. So our culture has continued into this focus on self, individual autonomy, and individuals being able to control every aspect of their life. When I was a kid in the 70s, my dad entitled this culture as the me, me, I generation. And so whenever any of us would start to act selfishly, and we didn't say please and thank you, and we took something that didn't belong to us, we were let known that this was not the way of living in Christian faith. And unfortunately today, there's an increased control over all aspects of life. Materialistic possessions and goals seem to be the norm. Young children, to succeed, they're told need to go to college. They contracept for a decade. And then when they finally decide to get married, now they are surprised that maybe they're an advancing maternal age and they don't have as many potential eggs to conceive with. So the current culture tells us that we can manufacture babies through in vitro fertilization, that we can control the timing of when we do everything. And the culture also tells people that people with disabilities are not as whole as the rest of us, but we can all surely admit that I'm not whole. I have my own disabilities. I have my own imperfections. And then that culture extends into disrespect of those of us that start approaching advanced aging. And in our advanced aging and the recognition of less value, culture tells us that suffering has no place in life, and that if we suffer and we're in pain, then we are vulnerable or we become a burden to those around us and to society. Then the most compassionate thing to do would be to aid us out of our misery. This makes us even feel more vulnerable. Everybody agree? And I was raised in a culture that the wisdom of our elders was something that was so valuable. We sat in Indian style in awe, listening to every word that our great aunts and uncles and grandparents shared with us. And unfortunately, if your kids are like my kids and your grandkids are like my grandkids, we have this horrible device that lets us see whatever we want to see while we block everyone else out around us, because this is truth and not the value of the lived experiences of our great religious and loving traditions. In healthcare, I've seen a decline in valuing or recognizing any purpose or reason for human suffering. It's a culture that rejects pain and suffering. Yet if we dig deep enough in our Catholic faith, we find beauty and meaning in the salvific suffering of Christ. And if you're like I am, sometimes I'm weak in this realization, and I need to stop and pause and remind myself that Christ suffered so that we could live abundantly. The Apostle Paul shares his own discovery when he states, "Now I rejoice in my sufferings for your sake." St. Paul rejoices in his suffering because all of these sufferings can help. And when Grandmom said offer it up, she meant offered up. We know that we can offer our sufferings for the conversion of sinners and for the salvation of those that we love. And we beg God for strength in our journey on the day that we meet him face to face in eternal life. But for those in life who don't believe or don't understand our culture of hocus pocus religious magic, we see a lot of despair. We see a lot of people who have lost hope. And yet, like today's readings, in today's Mass, we know that we gain our hope and we do not despair even though we do not see. And through faith and hope, we as Catholics can find purpose in Christ's obedience in our human condition. And by virtue of our baptisms, we can join our suffering to the sufferings of our Savior and try to make a difference in this world. Because of the world's rejection of pain and suffering, they want to create a medical solution. They want to identify a medical diagnosis, and they want to intervene with a medical intervention. We just received emails, not email, but it was an email with an article that was written in Canada where they discuss Canada as having one of the most advanced medical aid in dying program in the whole world. And anyone in the country of Canada can do a Google search, and if they identify as having insufferable suffering that they can no longer live with, no matter what the reason, they can schedule their own death and appointment with a nurse to admit a patient for their medical intervention, which includes aid in dying. A mom received a notification from one of her daughters that her 23-year-old son had scheduled such an appointment. He had type 1 diabetes and had just lost his vision. And he very quickly obtained government permission to make his appointment. And they had 2 weeks to be able to try to help their son change their mind. Thankfully, we don't experience an aid in dying agenda in this country as aggressive as that. But what I wanted to share with all of you today is the aid in dying legislation, the compassion in dying documents that the state of New Jersey have on their websites for newjersey.gov. This lecture is being recorded, and I'm going to share all of my slides, URLs, so that you can have access to information and look at things as you would like to view. And then we have a couple handouts in the back of the church today so that you can just see a couple samples of, we're going to talk about post and most and end-of-life decision-making documents and try to help you make informed decisions for you and your loved ones. But I just wanted to kind of give you a segue as to historical path that we're living through with the changes that are happening in medicine. So in Catholic healthcare, since I was a young girl sitting around the table with my grandfather, we talked about the beautiful new introduction of hospice care in the United States in the 1970s. And hospice care during the 1970s was not care that anyone frighteningly associated with aid in dying. And I can't say that more than 40, 50 years later, that's not the case today. Palliative care is care that's provided for those who are sick, maintaining comfort. And hospice care and palliative care through the years have been used interchangeably. The distinction in hospice care in the state of New Jersey and in most states in the country include, when I did home care, documents that someone was diagnosed with a life-threatening disease with a prognostication or a doctor predicting that death would occur within a 6-month time period. When we would visit patients on hospice in home care in Salem County, where I did home care practice, if a patient didn't die in the 6 months, then we could extend the care. And we provided palliative care, comfort care to people who were on hospice. And it's a holistic program that includes pastoral care services, social work services, and nursing care and nurses' aid care to help with the primary care for a patient with family members. And sometimes hospice care would include respite care because it's very difficult to be caring for a loved one 24 hours a day, 7 days a week without respite help. And many people don't have extended family that can help in that care. And so that's a beautiful thing. But with hospice care, patients are not permitted to be admitted to the hospital to receive life-saving interventions such as antibiotics, IV fluids, IV antibiotics, and any other type of acute care medical intervention. But that didn't mean that patients couldn't still go to the ER, and if they went to the ER, then they lost their hospice benefits. But people aren't always communicated with that they're allowed to change their status. Our individual autonomy permits us to consider the circumstances where we are and to make a self-determination that might be different than the hospice status that we have. And this is really important for all of us to understand. So if you have a loved one who has a terminal diagnosis and they're on hospice care in your county with their physician, and say they have metastatic bone cancer, and that's what gave them the terminal diagnosis. But somewhere in that time frame of being cared for, they get an ear infection that's really painful. Or they contract strep throat because a grandchild jumped into their arms and wrapped their little hands around their neck and gave them a hug and was in school and got strep throat. With hospice care, interventions such as antibiotics might be refused. And in that regard, that's kind of normal care. So the next area that I want to talk about is how can we as Catholics assess ordinary and extraordinary care? The rich history of Catholic bioethics since the United States and the Belmont Report and bioethics were being introduced as a new profession as early as the 60s and the 70s, made these distinctions. How many people have heard of that ethical deliberation in the Catholic healthcare of ordinary, extraordinary care? Has anybody? A couple people are raising their hand. So when I first was in nursing school, we talked about what's ordinary care and what's extraordinary care. But the distinction that we need to make as Catholics is that this terminology is based upon moral decision-making, not based upon hospital interventions. And that simple fact gets confused a lot in the hospital and for patients in the hospital. So discerning ordinary versus extraordinary care is an essential part of our moral deliberation. And when we talk about ordinary care in the faith tradition as a moral consideration, we as human beings are obliged by our faith tradition to take care of our human bodies. And that when we get sick, we're morally obligated to care for ourselves through ordinary means. So these treatments that are considered ordinary, we are morally obligated to use because of our respect for our own intrinsic dignity or the intrinsic dignity of one of our loved ones. Extraordinary care means disproportionate treatment interventions or treatment interventions that we can discern if we want to withhold or withdraw by exercising stewardship over our own life or a loved one's life. So I'm going to give you an example. So I used to be able to say I'm 54 years old and I'm a mother of 4 with 2 grandchildren. Now I have to say I'm 57 years old and a mother of 4 and 3 grandchildren. We just had a new grandson born about a week and a half ago. And so as a nurse, I would like to say that I just want to be a do not resuscitate. I've worked in the ICU. I don't want to die in the ICU. I'd rather be home with my family. But if I was diagnosed with, say, breast cancer, I'm morally obligated under the precepts of discernment, morally of ordinary, extraordinary care, that breast cancer treatment for a woman my age is well advanced, and I am obligated to utilize normal, ordinary means to preserve my life because of intrinsic dignity for myself and for my family and my loved ones. If, on the other hand, I was in a horrific car accident and I sustained life-threatening injuries, as a 57-year-old, I would be morally obligated to at least have the paramedics pick me up, send me to the emergency room, send me to surgery, and try to correct the injuries that I had, considered ordinary care and medicine today. But my husband and I have had many, many conversations, and if I became in a vegetative state, maybe with some neurological deficits, and I was going to only be able to be kept alive on life-sustaining treatment interventions, now over the time necessary, that could be considered extraordinary care because I no longer had my faculties about me, and it would be okay if my kidneys failed and my lungs failed to take me off of a ventilator. He would not be morally obligated to keep me alive on that ventilator for eternity, because we as Catholics recognize that the objective goal in our lived experience as human beings is not to live forever, but to make preparations for eternal goods and hope for the grace of a holy death. And being able to make distinctions between ordinary and extraordinary care for our loved ones when they are sick is difficult. It requires prayer, discernment, and conversations, and there aren't black and white definitions and answers. Dialysis might be normal care for one person, and it might be extraordinary care depending on circumstances for another. The National Catholic Bioethics Center provides 24-hour a day, 7-day a week, free ethics consultation services. So if any of you are experiencing specific struggles with end-of-life decision-making, you never need to feel alone. One of us is on call. If you put a consult in as a regular consult, we'll get back to you within about 3 business days, sometimes quicker. If it's an emergency call, then we have an emergency line for people to leave messages on an emergency line, and someone will get back to you as soon as possible. So if you find yourself in the hospital in the middle of the night with a decision that's really a gut-wrenching decision that you need assistance with as soon as possible, we provide those services. Unfortunately, sometimes we'll get an emergency service on the regular consult line, and we might see it 10 hours later. So I just want to alert everyone, make sure that you appropriately identify an emergent consult. So as Catholics, when we talk about ordinary and extraordinary care, hospitals and secular health care think that we mean ordinary and extraordinary care regarding a specific medical intervention. But we as Catholics know that circumstances, diagnosis, and treatment history is very important. And maybe the one thing that I would ask all of you to maybe write down and say, this is what we need healthcare providers to do, is it's our job as healthcare providers to assess and evaluate our patients, not once, not only on admission, not once right after surgery, but it's my nursing obligation to assess and evaluate my patient's needs every time there's a change in patient condition. And that might be every 10 minutes, it might be every hour, but we never base an ethical decision-making upon what might happen or what we think will project to happen in the future, but what is happening in that assessment and the evaluation in this moment in time. So as patients, I would imagine that most of our questions for today is how do we make that moral discernment, and how can I help you make those moral discernments? Number one, patients have to be competent, meaning you're awake, alert, and oriented, and you're able to make decisions. And as a competent individual, according to even normal secular bioethics, we are allowed to stop care, refuse care, question care, or change our care provider. My parents are now in their 80s. My mother had an experience with a lethal heart rhythm. She lost consciousness, drove into a fire hydrant in front of their town police station. Nice place to decide to drive off of the road instead of off the mountain that they live in central Pennsylvania. And she had quick first responder care. And when she was in the hospital in an ICU, Dad was really afraid to let me speak to the physician because they're going to think that they're not giving us care and we don't trust them if you talk to them. And we're getting really good care, and it's okay, DiAnn, you don't have to talk to them. No, Dad, I know, we trust the docs, but I have a genetic arrhythmia that I've asked everyone in my family to go get tested for, and everybody said, no, we're fine, we don't need to do that. And it was important for the cardiologist to know that, so he could test my mother for the same genetic test that she never went to get tested for. But my dad had over a 24 to 36-hour hesitation because he lives in a generation that believes that the doctors know what they're doing, and the doctors do not need to be questioned, nor do they need you intervening in your mom's care because, honey, I'm really afraid that if we do that, that they won't give us as good a care. Or what if they think we're going to sue them? No, Dad, it's not like that. Like, you're a healthcare partner. If you look at all hospitals' Joint Commission standard, have you all heard about patient and family-centered care? Has anybody heard that term? Every hospital that's accredited by the Joint Commission, who is the body that accredits their permission to take your money from Medicare and Medicaid, has to say that they provide patient and family-centered care. You, for yourself and for your spouse and for your loved ones, are the healthcare team. That's a paradigm shift for this generation, and I only know it because I work in healthcare. And I even succumbed to not asking healthcare professionals about my own heart arrhythmia when I was very young because I figured they just knew what they were doing. But we need to know and be participants in our care. We participate in decision making. We can develop plans of care. It's how we teach parents who receive poor prenatal diagnosis to not have medicine, secular medicine, happen to them, but to teach people to have a voice on how to be involved in their care. And we start by saying, hi, my name is DiAnn. I'm a nurse. I'm a Catholic. And I have beliefs and values. And these are the beliefs and values that I adhere to for the care of my loved one. And when they tell me that that's not the same as the physician's plan of care, for my patients that I advocate for in the hospital. We teach people to say, but doesn't your hospital adhere to patient and family-centered care? And I'm a member of the healthcare team, and I would like to discuss with you my values, my beliefs, and our outlook that we hope that you can help us provide for Mom during this difficult time as we approach her end of life. And if we can teach one another to speak with that confidence and say, I'm not trying to do your job, you are the cardiologist, but please help me to understand, and please navigate through me so that I can understand. And let's discuss how we're going to move forward. Does that make sense for everybody? It's a powerful tool, because as soon as you bring up, oh, your Joint Commission standard state, they go, whoa, where did she come from? Right? So we are part of that ethical decision-making. I had the blessing of being raised in a Catholic hospital system. I had the blessing of being raised by Catholic nuns. And Catholic healthcare has what's called ethical and religious directives of the Catholic Church. The ethical and religious directives of the Catholic Church are ethical requirements for Catholic healthcare. I tell everyone, go to the United States Council of Catholic Bishops website, type in ethical religious directives, and you can get your very own copy of the ERDs off of the bishop's website. And it'll help you to know what the Catholic Church teaches in beginning of life issues and end of life issues. At the National Catholic Bioethics Center, we meet every other year with the bishops in Dallas, Texas, to discuss the ethical religious directives of the Catholic Church, to discuss problems that are happening across the country, and invite doctors and nurses and other healthcare providers in providing assistance for the bishops to understand what we are experiencing in the trenches. So ERD Part 5, and I'm going to share these slides with you so that you can see and read some of these ERDs, talk about how we make those decisions of evaluating ordinary, extraordinary care. So it's important that you see that in writing. ERD 58 states that with end-of-life care, it's important to provide food and water for patients. St. Pope John Paul II's allocation, I always have trouble saying that word, addresses this very important point about saying it's never permissible to starve or dehydrate someone to death. And so it would be also true to state that it's never ethical permissible to refuse elements of ordinary care for any of our loved ones, including pain medication, including perhaps antibiotics for simply treated infections. And we've all heard on the news that providing water and hydration has been problematic for the care of people, and maybe we've heard horror stories where water and hydration have been withdrawn from a patient, and Catholics, because of St. Pope John Paul II's allocution, have tons of questions about hydration and nutrition. So ERD 58, it makes three distinct points in regard to how we navigate through the moral discernment for fluid and hydration. So in general, we have a moral obligation to provide patients with nutrition and hydration, including medically administered hydration and nutrition. Point 2 is that we have a general obligation to extend a person that might be in a vegetative state. They're arousable, they can respond to maybe few commands, hydration and nutrition. And number 3, we need to really discern and make a distinction between somebody's chronic state of needing hydration and nutrition versus a patient who's acutely dying. And this is where that ERD and St. Pope John Paul's statement caused a lot of anxiety for Catholics who know that St. Pope John Paul made that statement. And I want to kind of give you an overview in a case study that we were presented with at a UCLA nursing conference. And there was like 600 nurses across the country at this conference. Our host was from Georgetown, a good lifelong Catholic nurse. And we were split up into all these subgroups of all 600 people. And we were provided 2 case studies. And in the first case study, we had a patient who was in a nursing home who had dementia. I can't remember if they were diagnosed with Alzheimer's, but they no longer remembered or recognized family members. But the patient was awake, alert, and when the nurse's aides or family members would come and feed mom, she obviously didn't like some of the foods that they tried to feed her, and she would spit them out. And then they showed the video of mom eating her ice cream, and she clearly loved the ice cream. And she never spit it out, and she made noises and facial expressions of appreciation to whoever was feeding her the ice cream. And this woman had 3 daughters. And the case was based off of a real case in California when all of this aid and dying first began. And because of that news media realization, the 3 daughters said to each other, Mom would have never wanted to live like this. And so they requested an ethics consult with the nursing home. And they sat there and they told the nursing home, because Mom would have never wanted to live like this, we want you to stop feeding her and giving her drink. The case study stopped, and all 600 nurses were asked the question, is providing patients with fluid, hydration, nutrition, care, or medical intervention? And every single nurse said, well, that's care. We went into nursing to care for human beings, and providing someone with water and food is meeting a basic need, a basic physical need. And the daughter said, no, we don't think so. They're calling that a medical intervention now. And because we know Mom would never want to live like this, we want you to stop. The nursing home was flabbergasted. And they told the daughters, we need to meet with our ethics committee, and we will reschedule another appointment. It was determined that they would not stop feeding Mom. And they said, but we can't stop you from taking Mom home and caring for her yourself. And all 3 daughters gasped and said, oh, we could never do that. And they said, what, you don't want to take Mom home? Or you don't want to stop feeding her and giving her hydration? And they said, we could never not feed her. But they were asking the healthcare team to do what they could not. Very sad. So if we extend that into the Terry Schiavo case that maybe all of us are familiar with, I remember when that was all over the news of the husband saying, are we going to stop feeding her or not stop feeding her? And I can honestly say, my 30 years in healthcare, we gave hydration and nutrition, water in G-tubes, food in G-tubes to children that had complex medical needs and adults that had complex medical needs. And it was never, ever an issue of nursing not providing those interventions. But today, unfortunately, we live in a world where patients are stopping nutrition and hydration through feeding tubes for those who have suffered losses such as those. But on the flip side, when a patient is actively dying, we show physical decline in our functioning. Our stomachs don't have bowel sounds. We can't swallow. We throw up. We have diarrhea. We can't maintain any type of fluid status. And there is a time where we can stop fluid and hydration when a patient's actively dying. The normal dying process means that we stop eating and drinking because we are preparing to die. And we don't want to force feed people when they're actively dying because then we would increase their suffering. So when someone's dying, I can't give a feeding tube if there's no bowel sounds, and they're going to throw up and aspirate stomach contents into their lungs and get a pneumonia. So these are the ethical discernments that we make with each of you when you're experiencing these difficulties with your loved ones and family, to say, it's very permissible to stop feeding and hydration with a loved one when they are actively dying. And that requires us to assess and evaluate on the continuum of time. So every intervention that we provide in healthcare, pain medication, administration of antibiotics, administration of feeding tubes, IV therapy for dehydration, all fall under that framework of decision making. So I want to kind of jump ahead and talk about advanced care planning. And a way that helps us make those advanced care planning decisions is that in Catholic healthcare, we can ask ourselves questions that adhere to determining if an action is good or if an action is bad or if it's morally neutral. And then making sure that all actions like feeding people, providing antibiotics, they're good or morally neutral, or providing pain medication for a loved one when they're dying of cancer is good. But over-medicating a patient with an opioid so that their breathing stops is not the aim of the administration of the medication. When we deliver a pain medication, we're assessing someone's pain. We numerically number it if the patient's having pain on a scale from 0 to 10. And if someone's actively dying and they aren't able to verbalize their pain, as a healthcare provider, we're trained to assess pain. And when people are having pain, even if they can't verbalize pain, their muscles will be tense, their teeth will be clenched, and we'll hear them groan even if they can't talk. Patients' heart rates increase, blood pressure increase, and they have stress responses. If someone's quietly sleeping with stable blood pressure, heart rate, and their extremities are flaccid and they're not having physical symptoms of pain. So I was trained to administer pain medicine when patients stated they were in pain or had manifestations like they were in pain. And if someone's respiratory rate is very low and somebody's heart rate is very low, I don't keep pushing that opioid because that opioid can stop respirations and decrease heart rates farther. So this is another scary part for people when they're caring for loved ones. And a lot of times today, on hospice care, patients are put on continuous pain medication. And I'm going to tell you that I have provided continuous pain medication for my patients that have continuous pain. Metastatic bone cancer is probably one of the most horrific, painful experiences. There's other cancers that are very painful, but it's hard to stay on top of certain types of pain. Pancreatic pain, super hard to stay on top of. Patients will grimace their teeth, and I'm happy to provide that pain relief. But if your loved one is sound asleep, Cheyne-Stokes respirations or death rattle respirations, and they are not exhibiting physical pain, and people just keep upping a morphine opioid drip, That's called expediting death. And sometimes as untrained healthcare providers, you might need assistance in speaking to someone about what is happening. A lot of nurses and a lot of docs, they think they're helping someone. We do a lot of education and healthcare professionals to assess and determine those physical manifestations versus just knowing someone and putting them out of their misery. And I will provide everybody with a copy of the title of Sister Anne Sophie's book, where she, as a religious ordered nun, talks about instead of knocking our loved ones out so that they are not conscious, there's a beautiful element of maintaining pain control and having family members surrounding the bed, praying the rosary, praying Divine Mercy Chaplet, or just simply being present to hold hand with the ones they love. I had an awesome experience of watching my next door neighbor pass away peacefully in the arms of her daughter and myself. And it's a hollow moment when we watched a loved one cross over into the loving embrace of God. And the same tears that I shed at times of birth are tears that we shed at times of death. And many of us have witnessed loved ones passing where we know that they went to a better place. And we want that for our loved ones, and we pray for that for ourselves. So this is where I want to try to help you. How many people in this room have a durable power of attorney, a living will, or advanced directives? So people have advanced directives, some people have living wills. How many people have been approached and asked to complete a MOST or a POST, a physician order of life-sustaining treatment or a medical order of life-sustaining treatment? 2 people, 3 people in the room. Do you understand the difference between a durable power of attorney, living will, advanced directives, or a POST or MOST? No. So this is really important, and I provided everyone with a handout with checklists for healthcare providers in completing a physician order for life-sustaining treatment or a medical order for life-sustaining treatment, depending on the state is how they use it. The difference between a living will or advanced directive and a MOST or POST is that a living will or advanced directive, it verbalizes what we want or what we would like to have at the time of our death. So my whole family knows that I don't want to be on a ventilator in ICU for 55 days. I always say I grew up in the ICU. I don't want to die in the ICU. I want to be at home, right? But that doesn't take away my obligation to respect the dignity of the life that Christ gave me by avoiding moral, ordinary medical interventions if I were to get sick. But it would state what I want at the time of my death. Medical order for life-sustaining treatment or physician order for life-sustaining treatment is not an expression of what I want, but rather an order that's carried with me, and in our world of Epic and hospital computerized care, will go with you from doctor to doctor, hospital to hospital. And when we read a MOST or a POST statement, it makes us think that it's the same as the living will. And the New Jersey directions point out that it's permissible for any of us to change our mind. The word of caution at the NCBC that we provide for people is that it's more difficult for you to say that you're changing your mind because that's counted as a physician order. And it would need to go through steps to be reneged. But when we fill out a most or a post on the PowerPoint and from the handout that I will provide for you, is that language usually reads, the inclusion of the patient as being frail or not likely to stay alive for a long period of time, or it doesn't state that there's a terminal condition like a hospice order will. It usually uses vague language as in frailty towards end of life. I would or would not want a tube feeding or any other official invasive form of nutrition. I would or would not want cardiac resuscitation or a cardiac pacemaker. I would or would not want blood or blood products. I would or would not want mechanical respiration. I would or would not want kidney dialysis, or I would or would not want antibiotics. They're usually the components that a most or post would be. And if you said at end of my life, I don't want CPR, I don't want antibiotics, I don't want dialysis, and I don't want resuscitation or artificial hydration and nutrition, it's difficult for that order to be changed. And so we caution people that if you're going to make or fill out a most or post, that you specify that you would not one of those things if you were actively dying, because the determination of any healthcare provider to say, she's just frail, she's out of it, she's not awake, alert, and oriented, we're not going to provide those interventions because that's what's on that post or most, not determining the circumstances. So I want to give you an example. I told you I think that my grandmother lived to be 106 months old, my sweet little Italian grandmother. It was her husband, my grandfather, who was involved with hospice early on in the 70s, so they understood end-of-life decision-making. And my grandmother always told all of us, she didn't want it, Grandpa too, they didn't want to be on a ventilator. In my grandmother's 80s, if she would have filled out a most or post and said that she didn't want intubation, she was with all of us in Delaware, New Jersey area. She lived in Ohio. And she got the flu. She had been vomiting all night. She had a huge amount of diarrhea. And my uncle, who was a medic and a PhD chemist, called me up one morning and said, Grandmom's not looking good. You need to get over here. I think she might die, and we know she doesn't want to go to the hospital. So I drive to my uncle's house. And my dad and my uncle and my aunt, they're having coffee in the kitchen, and they're quiet, thoughtful. And I said, where's Grandmom? And they said, she's upstairs. She's been sick all night, and she doesn't want to go to the hospital. So I run upstairs, and she's on her knees, rosaries, prayer book, sound asleep, breathing really slow. And in my mind, I thought, such a beautiful woman. She's on her knees. She was dusky gray. Her fingers were cold and blue. And I wrapped my arms around her and I whispered in her ear, Grandma, I love you. And in that moment, we were all okay if that's the way she was going to die. My dad walks upstairs and said, oh yeah, she's fine. And he had a deep booming voice. She's only been in the bathroom with diarrhea all night. She perks up as soon as she hears his deep voice. Jimmy, I'm fine. And I said, Grandma, have you been sick? And apparently, she was very dehydrated. Her pulse was fast, her cap refills were slow. She was so dehydrated because somebody else in the family had had a flu too. And I said, Grandma, you probably need some fluids. I can't keep anything down. I said, let's go to the hospital and see if an IV helps. And she's like, okay, DiAnn. So she goes to the hospital, she gets her IV fluid. She had a few rocky moments. They thought maybe they were going to have to put her on the ventilator because she had pneumonia with whatever flu she had. And we knew she never wanted to be on a vent. God is good because we all prayed, and she made a turnaround without needing to be placed on a ventilator. She lived 20-some years later, right? And this is a woman who prayed for all of us, who said multiple rosaries per day, went to daily mass, and just was a fabulous faith example for all of us. If she would have had a most or post, if she had lived in a nursing home where this was a requirement, they wouldn't have started the IV fluid because she said she didn't want it, if she said that. So that's what I'm saying. Be careful. Be careful. Question?
Really coercive that they wanted us to sign this pulse. And when I read over it, I said, we're really boxing ourselves in here. There's no leeway with like consulting with a priest or ethicist. So we never signed it. But so I don't like, and there was Catholic, I think Michigan Catholic Conference wrote a nice article about it's good intention, but there's a lot of problems with it.
And that's a wonderful point. Did everybody hear him in the back? So paraphrasing, he had this similar experience and almost felt forced or coerced to fill out the polls, but they didn't have an opportunity to consult an ethicist or to discuss about the particularities, and so they decided not to sign the form. But this is a really big push right now, and it's a big change in healthcare. We had advanced directives and living wills for decades. I think where healthcare providers felt that this was frustrating is that many of us had our living wills and our advanced directives in a lockbox with our attorney wills for distribution of our financial goods in our homes. And so we coded every single person and revived every single person and maybe over-treated patients because we didn't have the advanced directives. You know, healthcare workers, I am one, and I've had to do chest compressions on a 98-year-old where with the first compression down, we fractured ribs. And it'll bring tears to your eyes. Medicine can do a lot of good, and medicine can do a lot of harms. But this is where assess and evaluate circumstances is so important. Since the computerization of healthcare documentation, original electronic documentation was based upon the airline industry's checklists for safety, patient safety and quality. It's improved a lot in the last decade, and it looks more like an old-fashioned hospital chart. But the initial documentation looked like an airport checklist. And when I see most posts, it looks like a checklist. And it doesn't take into consideration any special nuanced situations. So refusing to give someone an antibiotic because of an ear infection or strep throat when that would be categorized under ordinary care for moral decision making, if we have a checkbox that says, well, they're on hospice and they have metastatic cancer, but I can't treat a sinus infection with an antibiotic, or I'm going to not give someone sips of water because they're NPO. And another story I'm going to share with you, and then I'm going to stop and I'm going to let you get the forms. I'm going to show everybody. I have the Ncbc Suggestions, and if you go on the National Catholic Bioethics Center, we've spent a lot of time to talk about these nuances and the red flags to make. And we have, I might have left them. I might have given them to my husband, so I apologize. But I had to dig them out. They're right here. So there's an Ncbc guide to completing the post form. There's a Catholic guide to end-of-life decision-making. And then we provide a sample post form for Catholics. If a nursing home requires that a post form is completed, which this is becoming the standard of care in extended living and nursing home facilities across the country. And so you remind people that it's patient and family-centered care, and you have access to your own post-most form. You don't want to use the state's post-most form, and it'll include that they need to take into consideration circumstances, and then I would get somebody who is an ethicist to help guide you with clarity of language for that completion. And then there's another organization that's very important for everyone to know about, and it's called Alliance Defending Freedom. Anybody familiar with Alliance Defending Freedom? We utilize their services. It's more of a legal component of healthcare support. We deal with moral, ethical decision-making. Alliance Defending Freedom helps us if we have legal questions regarding healthcare and the legalities of some forms and questions. They help with what is conscience protections, and everybody, by the state determination laws, healthcare workers have the freedom of conscience protections. So I don't have to be mandated to scrub in an OR for an abortion. I don't have to participate in administering a lethal dose of a medication. And as that statement is made, it's not legal in any state in this country for a healthcare provider to provide a lethal dose of a medication for any one of our loved ones. And I'd like to say that it never happens, but I can't. Because some people hide their administration of some medications in with the patient was in pain and they needed to provide that for their comfort. There's a lot of quality of life issues with healthcare providers. And I'm going to say that there's a lot of trauma and hurt and pain for a lot of healthcare providers that unless you're a healthcare provider, we don't understand. And we want to give voices to healthcare providers to manage that moral distress, but not take life and death decisions in their own hands for what they think is best for another human being. It's being kind of demonized with the use of language that if healthcare providers state, I can't provide that medication for Mrs. Jones in their home, and I can't provide education for them to teach them how to take that medication so that it expedites their death. That's what medical aid in dying is that the physician or the prescriber gives a medication and the person is provided education on, well, when it gets too rough, this is what you take and this is how you take it so that you can successfully end your own life. From my Catholic professional moral standing, I will never participate in that because I am cooperating in aiding someone instruction for them to commit suicide, which the medical community will not use that terminology. Suicide, physician-assisted suicide, euthanasia are words that are going to be erased from the healthcare profession to utilize these euphemisms that say, we're providing autonomous provisions of care because that's what the patient wants. And then we're being told that if we don't do that, then it's a violation of our professional code of ethics. And the last thing I'll leave with you is that the professional code of ethics for nurses clearly always said in one of their provisions that it is never ethically permissible for a nurse to ever give a medication with the intent of the patient dying. It was always clearly part of the American Nurse Association Code of Ethics, just like the Ethical Religious Directives of the Catholic Church. It's a fluid document that has been around since the early 60s probably, and it changes. The 2015 American Nurse Association Code of Ethics proposed change in the language that if the patient requested medication for aid in dying, that the nurse was obligated as a nurse practitioner to prescribe it and the nurse that was at the bedside to administer it. And the roof raised across the country. And we and I submitted so many letters to the Board of Nursing that this was not an ethical, acceptable code of conduct for professional nurses. And what they passed was a neutral term that no longer said that it was unethical, but they didn't say that we were ethically obligated to comply with patient wishes. It's a neutral term on purpose to flatten people's objection with the intent, I'm sure, to eventually change it. As soon as they change it, then legally, by my registered nurse license, I could be mandated by the government to provide a medication if a patient wished for it, maybe without having conscience objection to it. So I'm going to end with that, take questions for everyone. I think I went over time, so I apologize for that. Okay.
First of all, thank you very much. So, do we have any questions?
During my preparation of estate planning for the living will, I looked at the New Jersey Catholic Conference. They have a form that you can use. And I wasn't happy. It was almost not quite as bad as the polls, but there were some check-the-box type things. I looked at Pennsylvania, because that's where I grew up, and they had Pennsylvania Catholic Conference, a really nicely written one that gave room for the, like you say, the nuances. So I asked the lawyer, he said they'll accept it from any state. So I actually used that, the Pennsylvania form, maybe crossed out Pennsylvania, put New Jersey and date an initial and that kind of thing, and listed the definitions of New Jersey. So that might be an option for people who don't like this check-the-box stuff. The Pennsylvania Catholic Conference Living Will is a really nice document.
Thank you for bringing that up. So living wills are a signed, witnessed, and notarized document that allows patients direct specified life-sustaining treatments to either be withheld or withdrawn. And in the 70s, the question was, if I put somebody on a vent, is it ethically permissible to take them off the vent? Or if I put somebody on dialysis, is it ethically permissible to take them off? And through that ethical deliberation, it is through the principle of ordinary, extraordinary care. As soon as we know that a patient's not getting better, they're exorbitantly suffering, and it's something that's not a bridge to recovery, but further terminal outcomes. So that being said, that can change, and the attending physician has the authority to carry out the directives in the living will. With Be Not Afraid, Lily's Gift, and we develop a birth plan for babies that are diagnosed with complex, fragile medical needs because of genetic abnormalities. And we instruct families to say, what's your birth plan? What does it look like? And there's always room for assess and evaluate, because sometimes babies surprise us, and sometimes grandmom surprises us too, right? And it's okay. We love to be surprised. God has his own plan, and sometimes he uses those surprises to teach us that he really does exist, right? And there are miracles that still happen today. And sometimes we don't witness a miracle, and we lose the ones that we love, and they're gained in heaven for eternity. So we need to be more conscious about developing a document for a plan of care for our loved ones with multiple complex older health needs. Grandmom with dementia, grandmom with advancing Alzheimer's, somebody with advancing neurological problems, someone advancing cancers, someone advancing complications from diabetes and congestive heart failure and COPD, right? However many illnesses and diseases that we have. And be able to say, please respect our family's plan of care for our loved one. And we won't just say objectively, this is always right, this is always wrong, because life doesn't work that way. And we also have to understand that insurance providers pay a lot of money for us when we're sick. And the easiest thing for them to do is discontinue care so that they don't have to put out the money. Right? There's other sad stories where some siblings will want grandmom to live forever because they're collecting her Social Security check, and that's a whole nother ethical issue. And that's not one that we're here today for, but it's one that we have to carefully navigate through in the hospital. Any questions with regard to ordinary, extraordinary care and any situation that you've experienced for yourself? I kid and say I want to be a DNR, but I have never made myself a DNR because I'm not morally able to do that. So, question in the back.
We're recording this, so we're using the mic so people who look at the recording later can hear the questions.
A personal experience. I was my mother's healthcare proxy, and at 2 months short of 99, she had a stroke. And it was probably 2 or 3 hours before she got to the hospital, and she was totally non-responsive, although her eyes were open. And about 3 or 4 days into her treatment, I made the decision to talk to the nurses and ask to stop hydration. Now, I thought that's what she had wanted, and there was no prospect that she was going to recover, although she might linger for a month or 2 months until she had a blood clot and then a heart attack. I've not really been troubled by that decision. And I hear you say a person who is not going to recover and in the throes of expiring, that would not be an unethical decision. I certainly did not believe I was making an unethical decision. I've thought about it over the last 16 years on occasion, and I realized that was hard, and I pray that it was correct.
So, God bless you, and none of those decisions are ever easy. And so I do want to put your conscience at peace in saying at 99, having a stroke, was your mother able to sip water herself? Or she was on IV fluids in the hospital and she wasn't awake, she wasn't responding? Yeah, so none of those things. So this is where I said it's so important to know circumstances, right? So she was receiving hydration via artificial means, which is IV fluid. So in and of itself, receiving IV fluids is not morally bad. It can be morally good, or it can be morally neutral. So when we're faced with an end-of-life decision like what you're mentioning, with a devastating stroke, with not a good outlook on outcomes, with no responsiveness, and her inability to swallow those fluids would have been like she just couldn't. And so in that circumstance, it's different than a very young lady like Terry Shivo, who was in a vegetative state and who could even take some PO. I think her mother and father were trying to feed her PO, and she couldn't consume enough fluids and nutrition to maintain life. But at end of life, and I would claim that you probably experienced an acute active dying at end of life, and then we aren't morally obligated to never-ending fluid and hydration. IV fluid infusing indefinitely has risks and harms. We've seen family members that blow up from IV fluid, that get edema, that have congestive heart failure, and then they have fluid volume overload and crackles in their lungs, and they suffer even more. So thank you I try to always take pause in a patient who can eat, who is healthy enough, in a chronic state that can have hydration and nutrition. We are morally obligated to provide that for them. But I would argue your experience with your mother was an acute, active, dying situation, and so therefore not continuing that fluid hydration is morally permissible. And if you would have consulted an ethics consult at the time with any of us at the NCBC, we would have sympathized with your difficult decision making. And did your mother die not long thereafter? Yeah. So she was actively dying. So please be at peace with making that decision. And that's where it's a good example of these ethical decision makings are so complex that we have to determine everything in that moment in time. So I can never say always or never. We have to assess and evaluate with those circumstances. So I hope that helps. What's problematic about it is that people want to know for sure, but we have to discern in that moment of time. And with her imminently dying that quickly, there was nothing else you could have done. So did I confuse anybody else with that review? And it's not even confusion. I think it's a great clarity, and I'm so happy that you brought your experience and shared your vulnerability in that experience.
That form, pulsed or mulched or whatever form that a person, can you hear me or I don't know?
I can hear you okay.
It's close. All right. So who enforces those forms? Because sometimes family members try to interject and override what's the wishes of the patient. So is it like a doctor or nurse who says, oh, hey, no, she wants this, and that's what we're going to do for her, and not let the family kind of override the patient's, I don't know if that makes any sense, that question.
No, it makes sense. So your question is, who fills out the form, who kind of continues or ensures that the orders are consistently implemented? Every state's different. The New Jersey form that I printed for you was purposefully not for patient post-most directions. It was a provider instructor sheet. And at least in the state of New Jersey, a nurse practitioner, physician assistant, or physician are the ones who, on the New Jersey provider sheet, needs to complete the form. Some states, it can be like a medical tech, and they're just running around in the nursing home getting signatures. From our ethical viewpoint, it should be a family and patient decision. And I think that some adult children have been surprised to learn that their parents who are elderly completed one without it ever being a conversation in the family. And there might have even been issues of whether or not mom or dad had complete capacity to be able to understand what was being presented to them, and certainly to be able to understand that it was an order versus a wish. Certainly, were they documented that the person fully understood that it was kind of a blanket statement and not circumstantial. Many people do not understand that that's the case. And then adult children then have difficulty changing it because that's what your mom said she wanted. So we're doing nothing. I say that it's important that we know that in the state of New Jersey, that at least an advanced practice nurse or a physician would make the order. And we were all surprised to learn that in some nursing homes, just someone who's prescribed that job to walk around the nursing home to get everyone a post-most form completed, it's not originally signed and witnessed by the doctor, and then the doctor signs it later. And in healthcare, as a nurse, when I get a consent for a patient for surgery, I can't have the patient sign the consent with only my signature. The physician needs to be with the patient, and they need to provide risks, benefits, alternate treatment interventions for every intervention that they do in a healthcare system, which would include a person filling out post-most. They should be instructed on, these are the risks for filling this form out, these are the benefits for filling this form out, and these would be alternate decisions that you could make, and then someone's fully informed to fill out their wants and their requests. And we all know that when we go to surgery, they just ask, do you consent for this surgery? And you sign the paper. Rarely do we hear all of the information that healthcare providers should provide for us, or they just give you a 20-page document and say, read it, and let me know if you have any questions. Did that answer your question?
Other questions? More exercise.
I'd like to ask, my mother passed away at 94, and I don't recall that she had been very sick at 88. She was dying, and nobody knew my mother. And the doctor said, we want to put a DNR, over her bed. And I said, no. I said, give it a few more days. If my mother's not conscious in 3 more days, then we'll discuss it again. And of course, my mother was conscious, and she was out of bed and, giving all kinds of orders and demanding all kinds of stuff. I didn't feel guilty about saying, no, I don't want a DNR. She was having seizures. She had sepsis. It was everything. She was bleeding internally, and in 3 days she was fine again. So that was okay. But I don't ever remember them coming to me with this paper. And I'm wondering, is it because I had her in a Catholic hospital?
Post and most are fairly new.
Oh, okay. But
I'm not-
does that make a difference if it's, the fact that it was a Catholic hospital?
No, I think that Catholic healthcare systems adhering to the ethical religious directives understand that they're problematic.
Okay.
But the documents are attempting to become standards of care through government agencies and Medicare, Medicaid
So
type.
Catholic hospital cannot refuse.
Catholic healthcare can adhere to that, But if they adhere to the ethical religious directives, they're also going to understand the benefits of assessing and evaluating during certain specific circumstances, and not limiting people to making a decision about 5 years from now in a situation that we don't really understand or have yet to be able to see unfold.
I was just worried about the ethics, and if the Catholic hospital can refuse to do anything that would jeopardize the person's right
I
to
think
life.
nationally they try their very best. I think, Dr. John Haas, the old president who's still with us at the National Catholic Bioethics Center, he is very famous for saying, we in Catholic healthcare promise to not kill your baby, not kill you, and do everything we can to help with your spiritual salvation.
Maybe one more question. Anybody? All right, two more.
I have two questions. One is the duration of the forms you sign. They're about 10 years old now. If nothing has changed, how often should you review them?
So I didn't hear one of your words. So you have two, are they post-most to be signed?
No. These are old DNRs and
Oh,
all the documents, but they're 10 years old that I signed them. Should you keep them or should you review them at some point?
that's a great question. Your do not resuscitate orders have been in place for 10 years.
Yes,
And are they for you or for a loved one? For a surrogate?
me.
For you?
my wife has already passed.
Do not resuscitate. And is it in a living will or in a durable power of attorney? Like, is it on your healthcare record at your doctor's office? And so I guess my question is that the DNR orders are a little bit more specific today than maybe they were 10 years ago. And now the DNR, when we say do not resuscitate, then that would indicate that you don't want anybody to do CPR if your heart should stop and you were, should go under cardiovascular or circulatory failure. In the hospital, it would mean the same thing, but now we separate like a do not intubate, do not do chest compressions, do not, and then the other question is that what happens a lot of times, if you hadn't shared with us that you were a DNR, if you had some type of cardiac dysrhythmia and fell over in church, you're probably going to have a doc and a nurse come over, assess your pulse, and if your pulse stopped, would start CPR because so many people are trained today, right? And unless you had a DNR tattoo on your chest, we might not know, or your loved one wasn't with you, we might not know. But once you got to the hospital, they should be able to pull that up on your medical record. So maybe it would be wise to have a conversation, especially with your primary care provider, about whether or not the documents have changed or if you should take another look at charting that order. What healthcare providers used to get frustrated with was 99-year-old grandmom who had a DNR order and nobody knew or found out that she had a DNR order until like day 2 or 3 in the ICU. And we had really caused a lot of suffering. And that's what people had problems with the old living wills and advanced directives that were in somebody's lockbox in their closet in their bedroom. And that's what the post-most was seeking to avoid or to get rid of. So there's not an easy answer for your question. And I'm not sure if your doctor would say to you, let's look at a post-most instead. But it might be worth having the conversation again.
Thank you, that was good. The other question, though, is for those of us who travel. We do all of our forms in New Jersey. You're traveling in the United States, you're traveling out of the country. What happens?
So it depends on if your healthcare system and your doctor are in what we call EPIC documentation systems. EPIC is transferable across the country. Like if I signed into your hospital chart in Epic, we would have shared access to health records in that universal system more likely than in the past.
Thank you.
There was, I think, another question up here.
Last question, and before I forget.
Sure, you want a quick comment for his?
The comment was, she carries a copy in her suitcases. So that's a good idea.
That
I like
is
the
a good
tattoo
idea.
idea myself. I think that tattoo idea is a good idea. And before I forget, DiAnn said they do a lot of pro bono work, and I've been asked if you want to make a contribution. We do have a contribution box in the back as you walk out. I know some people have already made contributions, donations, so thank you very much. Okay, last question.
My question is in regard to those new pollster forms that you have. I'm a relatively healthy, praise the Lord, 73-year-old, and I actually get offended when I go to the doctors for my wellness visits because they're more concerned with, well, are you ready to die? Do you have everything written down? And let's do all of these tests that we need, like start in December and give me the months of the year backwards. Come on, you probably can't do it yourself. But that's not the point. With regards to the pollsters, my point is if I chose to fill out a form like that, I wouldn't do anything without consulting with my daughter, who is a nurse. But if I chose to do that and I chose to use my own handwriting to put extenuating circumstances in there, would my family members have a challenge saying, well, it's not really part of the form, she's just adding, we don't have to pay attention to what she wrote?
They would have to.
Okay, so if I
Under autonomy.
Okay.
So even when I sign my consent for an OR in a teaching hospital for a cardiac procedure, I write in there, only the cardiologist is performing the procedure, no residents in training to do my ablation, please.
Amen. My daughter was cardiac intensive care. I understand what you're saying. But the reason that I bring that up is that we just had a situation with family members just this past Labor Day weekend. We were all sitting on the beach. I have a niece who is an ER nurse, and her in-laws were there, and the 97-year-old mother, the grandmother, is dying. She is in what you called actively dying, but in severe pain due to a urinary tract infection. And what that poor family was going through, trying to get her to just get to the hospital, to the emergency room, so she could have medication to relieve the pain from the urinary tract infection, it was my niece who was actually able to advise them exactly what to say. That is how complicated our system has become.
It is. It's a shame.
If you don't know someone, you're really stuck.
And we always treated urinary tract infections, and women, especially at end of life, are prone to urinary tract infections because of the way our bodies are with pH levels and things. And if we're going to give compassionate care, to give something to decrease spasms, to decrease pain, and to give an antibiotic. Now, antibiotics won't work forever because people get resistant, but at least to try to symptom manage. But then it'll get labeled in healthcare today as futile care. But then we're gonna, so it is problematic. And that's why I think it's important, and I thank every one of you to come. We need to have grassroots education sessions for pre-Cana couples before they get married about complications that can happen before birth. We need to be having like lunch and learns like we did today with all of you, just to be able to talk out and have these discussions. So that we don't feel alone, so that we can maybe understand language to utilize or resources to engage with. And please never feel alone. That 24-hour line for ethics consults is there for every single one of you. We're local in Philadelphia, and we answer questions across the country, and we even answer questions internationally if they come in, because we will talk to you about your particular circumstances in your particular moment and help give you peace of mind and lead you towards being able to feel free of any guilt with the care that you're providing for your loved ones. So God bless every single one of you. Thank you.
Well, DiAnn, on behalf of St. Mary's, thank you very much. I think we're all better informed now, a little scary about we don't know what we don't know and we know what we don't know. So it's very scary in terms of our obligation to get as informed as possible, and with sessions like this, we will become more informed. Thank you.
And I'll provide everyone with the PDFs and samples, and don't get overwhelmed. Just look at what makes sense to you. All right? Thank you.
And thank you to our AV team for recording this session. Thank you.